Good afternoon, everyone, and welcome to the Health Science Talk. Today we have our presentation with Dr. Jade Khalife. The talk is about COVID-19 at 5 years, myth, paradigm shifts, and the air we share. Dr. Jade is a researcher practitioner with a background in medicine, public health, and epidemiology. His work experience includes being involved in the field of health systems for over 15 years, spanning several countries in the West Asia and North Africa. His activities have included developing the hospital performance model for the Ministry of Public Health in Lebanon, national strategies for health systems, tobacco control, and the evaluation of hospitals, primary care, and health interventions. He is affiliated with USG and lives in Denmark. Welcome, Dr. Jade.
Thank you very much. It's a pleasure to be here and see familiar and new faces as well. I'm going to be talking today about COVID at 5 years, myths, shifts, and the air we share. We'll just go straight into it because there's quite some material, and I followed a different approach across these. There are some more traditional slides and material in the first part. The second part will slip into various studies for an overview because there's been so much published on COVID, over 400,000 articles in peer-reviewed journals. We're not going to be covering all of that, but I've been very selective in choosing the most relevant journals, most relevant papers in various journals. So the first thing, just to go briefly over the myths that we will be shattering across this session, such as that COVID is just a cold, or it's over herd immunity, or it will weaken and eventually become harmless, or only the vulnerable need protection. Broadly speaking, we're going to be talking about 4 paradigm shifts, and that is really the core of the presentation or of this session. The first is COVID-19 is airborne, not droplet-driven. The second is we need deterministic and probabilistic evidence for effective prevention. Infection causes chronic harm, not only acute harm, and there are no good respiratory infections. So we know, we've seen over the experience of the past several years, particularly the first 2 years, we had different pandemic approaches in different countries. Not all could be really considered as strategies. There were a lot of approaches and some strategies. There were some intentionally harmful actors. We know that. There's been a lot of investigations done into this, such as Koch Industries and others that have funded different movements, only for economic benefit. But much more broadly, perhaps a bigger factor, I don't know, but certainly many more actors were caught in either outdated or wrong paradigms and remain trapped in it. And some have broken free, but it's a process. It's a process that takes years. So despite numerous successes we had regarding the pandemic, we have failed to stop COVID-19. So at a much higher level, we have failed regarding this pandemic. Not individually, not us, just broadly speaking. And it is, of course, a big challenge for humanity. Just very broadly, when we strategies or approaches, some countries followed between 2020 and 2022 mitigation approaches, including Lebanon beyond let's say, around summer 2020, we shifted from containment into mitigation, which is a failed strategy. Mitigation is not something we should have gone into, but other countries should have gone into, because this is something that humanity faces with such an infectious disease. We need a containment approach, and some went a step further in what is called zero COVID. This is when we talk about deaths per million till 2022, because we have a lot of counting and under testing happening over the past 2 years. So it's and here we see in Lebanon more specifically the catastrophe that ended up resulting in several thousands of deaths. When we really want to have an idea of how COVID is still ongoing, we look at wastewater surveillance. So we see here in the US at the national level, and there are different countries that have not so many. In Denmark, they also have it, the wastewater surveillance. And we see between 2022 till can we take that thing off if you don't, if it's possible? But until 2025 or 2024, we have different peaks happening, about 7 or 8, and this is broadly. In most countries, we've had about 8 to 10 peaks, and sometimes they are a bit, or one follows the other. But this is what we're seeing. So from wastewater, we that COVID is still ongoing. Whoops. I need the pointer, I think, isn't working now. So okay, that's good. Okay, so digging into the first paradigm shift. So why is it important? We're going to see why it's important to realize that COVID is airborne and not droplet driven. And it's a very interesting history behind this. So it's also a very interesting learning exercise for all of us. For myself, it was, I think for a lot of people as well. We're also still in the process. As many of you know, there was a miasma theory, which eventually, so over here we have the dominant thinking regarding diseases propagating through the air. Most, many, few, or none. And the miasma theory was dominant for quite a long time. Now here we're talking dominant Western thinking. There's also in other parts of the world as well, other thinking as well. But this is much more documented, and we will see how it became very consequential in the 1900s and in 20th century, broadly speaking, until today, because we, of course, know that some countries in the world that have many more resources and have been much more influential when it comes to science 100 years or so. And of course, things develop and everyone builds over each other. But this is to give a broad idea. So there was a paradigm shift around 1850. We started to get into the germ theory. What was discovered is the importance of water, hands, and mosquitoes as a vector also for malaria. We have over here, and around 1920, 1910, 1920, there was a resistance. There was some recognition, some doubts on whether or not some diseases transmitted through the air. But because of the last paradigm shift that happened along with the germ theory, some very influential people were very hesitant to accept the idea that any diseases were spread through the air. It was more the thinking of the germs or the disease, the illness is trapped within the body, and it can only spread from somewhere nearby the body through droplets. So we had resistance to the air, to the concept of airborne transmission, with some exception for tuberculosis, because the evidence was quite strong for that. And eventually here we start to have more acceptance. Other diseases are also transmitted by through the air: tuberculosis, measles, chickenpox, and now COVID-19. And there are several others as well. So we're in at this moment in history, we are in an important paradigm shift. When we talk about droplets and aerosols, here we're talking, broadly speaking, to visualize it, and we will get into this a bit more closely soon. We talk about large droplets, which are particles, let's call them that for now, that are above, that are more than 100 micrometers. So 0.1 millimeters. And then we have large aerosols and smaller aerosols that spread through the air. So this is a key figure to understand that droplets, typically the idea is that they drop to the ground within a short distance, but the aerosols, they can spread. And importantly, you see the concentration of aerosols here is quite high. This will be very relevant for what we see soon. So of course, there are stages in this process, and an important is that these particles or these aerosols different sizes. It's not just one or another size, but there's a whole spectrum. And of course, some sizes are much more consequential because they're further into our lungs. We'll come back to that in a moment. Broadly speaking, this is one way to conceptualize the aerosols with one or more virions within it. And there are different factors, of course, that affect how long it will survive in the air and how far it would go. We see how long, for example, they can hang in the air. 100 micrometer aerosol for roughly 5 seconds. 5 micrometers is much smaller, about half an hour. and even smaller for still longer. So a droplet transmission, we spoke about that there was a mistake to also in the understanding of some people and thinking that it's discrete. And the flawed assumptions and logical fallacies which happened by some infectious disease physicians in the 1800s. Speech, for another important part, it produces about 100 to 1,000 times more aerosols that are less than 100 micrometers in size for every droplet that is more than 100 micrometers. So there's just a larger quantity of aerosols that we see in the air. There's just more of it. Speaking likely overall produce more aerosols than coughing, because coughing, a single cough is going to produce more than a single breath. But you breathe a whole lot more than you cough. So it's a matter of frequency as well. That's not samples, for example, from a medical clinic at 42% of influenza A virus RNA was in the size of less than 4 micrometers and much less for RSV. So it also can vary by different viruses. Daycare centers, planes, health clinics, more than half of influenza A virus was found in aerosols that are smaller than 2.5 micrometers. So Charles Chapin was a very influential infectious disease physician in the early 1900s. And there was unfortunately a mistake in this. And here we're still coming out of the paradigm shift from miasma more into germ theory. And there was a mistake over here that there is no evidence that airborne transmission is an appreciable factor in the maintenance of most of our common contagious diseases. This is turning the absence of evidence of absence, which is something that actually has happened repeatedly in other times. Later on in the 1940s, 50s, and 60s, William and Mildred Wells, couple, they did several experiments. The most interesting of which was one on installing UV lights at school. They had variable results because the first time they did it at a school in some classrooms, it was very successful. Regarding measles and chickenpox, but when it was repeated on a larger scale, including other schools as well, they had mixed results. Why? Likely because there were different factors also at play. In the real world setting, there are other issues at play, and most likely it had to do with the public transport by bus to different schools. So it was no longer in one single setting. Then they also did a very interesting experiment to do with guinea pigs having UV air. They would have TB patients on one floor, and above the hospital, at the very top of the hospital, they had another floor which was filled with guinea pigs. And they did an experiment where they did not clean the air. They just had it pass through. And they would have on average about 3 guinea pigs infected per month with TB. When they used UV on the air vent that was passing through, there were none. So, and then there were others, like for example, Langmuir's barracks experiment. And over here, they also learned that aerosols smaller than 5 micrometers can penetrate deep into the lungs. Unfortunately, there's a lot of research which was used in terms of for potential use in biological weapons. So that was something that was not publicly available. Not all the evidence that we had was publicly available. So that was, of course, a setback. Throughout history, there's been many times that we have had, in real-world settings, some interventions which were not entirely understood sometimes, but they did sometimes work. For example, the Spanish flu didn't start in Spain, but that's what we call it. So different cities, we can see the differences in terms of the burden of different cities, those that took measures for clean air, for ventilation, or stopping public gatherings in indoor places like theaters and bars for a few weeks. We can see what a big difference it made in the burden of disease in those places. Chicago was a very clear example. And in recent years, there's more recognition again of the importance of airborne transmission in different diseases. This is from the CDC guidelines in 1994. So there is some recognition about tuberculosis and about the issue of cough, speaking, and singing. So broadly speaking, the flawed assumptions, when we talk about flawed assumptions, These are the top 6. First was the absence of direct evidence in favor of transmission taken as evidence refuting airborne transmission. So just because you couldn't prove a thing doesn't mean you should assume it is not there. And also because contact and droplet transmission occur in only during close contact, all close contact transmission must be contact and droplet. But we saw earlier the concentration of aerosols that is very near a person. It's just like smoking. The smell is strongest, closest to the smoke. Again, and because the large droplets are smaller than the lumen of the smallest bronchioles that we have, they can reach the target cells for SARS-CoV-2 in the alveoli. We will see something about sizes soon. And again, another thing was in different disciplines had different understanding of what it is and an aerosol. And that another one is aerosols are produced in significant numbers in infectious patients only during aerosol generating medical procedures. We will see about that soon. And the last one is only respiratory diseases with R naught or transmission, let's say, such as measles are airborne. Those that transmit, let's say, a person can infect 5, 6, 7, 8, 10 others. May be considered airborne, or 20 others, versus one that might, on average, transmit to 1 or 2. So this is conclusion, because even though this 100 micrometer particle can go through into the bronchioles, here you can divide these by 1,000, equivalent to millimeters, but that is not how it happens. And these particles as well, this is one of the main issues, is that it's not a straightforward going in and deposition. What happens is they overwhelmingly deposit in the nasopharynx because particles don't follow a straight line. So they hit and rebound left and right and get stuck on the mucosa. And this is perhaps one of the biggest or the main issue, is that there was a flawed understanding or mix-up between this maximum size that a particle is infectious, most of it mostly below 5 micrometers, with the maximum size that can be airborne. So, and here we see from experimental evidence, we can see the deposition by diameter. This is in the nasopharynx mostly when we're talking this size in micrometers, and here alveolar is much more over here, and this size is dominant. Of course, we're having a mix of these, but here, if we compare aerosol generating procedures, for example, on the right side, and compared to breathing, talking, exercise, shouting, you can see that big a difference. Anything without breath is producing aerosols. So the whole construct, there's no face or construct validity when it comes to aerosol generating procedures, why they should be any different activities that we do. We had some clues early on, like the Skagit County choir, for example. People were distanced, but almost 90% of the people in that choir, despite the distancing between, ended up getting infected by one person and eventually having one fatality, I think, from that. There are some other technical issues. One, just for example, was some people considered that you needed to be able to culture a virus from the air directly. But unfortunately, a lot of the methods used to collect these end up damaging the virions. So that was a bit more challenging. So you had to use much more delicate procedures, which were eventually carried out. And it has been successfully cultured from the air. We can see different types of different methods used to confirm the airborne transmission of diseases. Have all of this material, of course, after this. You're very welcome to have this and look up for yourself. Don't take my word for it. That's also a very important thing, I think, that we learn. We have to be critically thinking about things and check at least some things for ourselves. So broadly speaking, what is making also things a bit more challenging is that there is a move towards more and more increased insulation of homes so that we don't have as much loss of heat happening and this is going to be more and more an issue for energy efficiency, right? And in some countries you have energy ratings of houses and they cost more to buy. You can sell them for more if you improve their efficiency, energy efficiency. But what does that mean? That means you're blocking also fresh air coming in, because 100 years ago, or let's say between 100 and 200 years ago, there was more and more houses and buildings being built in recognition of the importance of fresh air. It included things such as, besides having large windows in some public buildings, but also ensuring that through the floorboards, air can come in and go out from other locations. So there were different things. Unfortunately, this from the medicine, they recognize this, that one of the challenges we're having is this issue of balancing energy saving with ventilation and public health. So we've been losing out the ventilation and public health part. Hospitals, modern hospitals have higher standards, of course, but they should be higher still now with the challenges that we face in the pandemic age. We had early warnings, for example, from some Chinese researchers in February 2020. They spoke about how COVID-19 transmitted by airborne transmission. But unfortunately, the broad establishment remained stuck in the droplet paradigm, and the evidence coming from aerosol scientists was largely ignored. We still have this heritage, the dominance of the Chapin's paradigm, which was very useful for various diseases. But unfortunately, it's a stronghold, particularly regarding infection prevention and epidemiology fields, made it very difficult to accept a paradigm. WHO and CDC accepted transmission of SARS-CoV-2 only in April and May, respectively, 2021. So it was quite late. And there was public engagement and follow-up was rather weak. WHO has done much more since then, but still, this is still unfortunately online. This was the critical mistake back in March 2020. There was this fact check on tweet and social media. So COVID is not airborne, which was really genuinely a critical mistake, even though they had been already contacted by aerosol scientists and had discussions with them. Fortunately, in 21, now we have acceptance of short-range aerosol and short-range airborne transmission. It can also be long-range, but it's predominantly the shorter range that is an issue. That reminds me, I forgot to put something on the table. Let's see. Just give me a moment. Aha, there. We'll keep this for a bit. So this is CDC's recognition. We shouldn't also fall into the trap of all or none. Just because we can't protect everywhere from everything doesn't mean we shouldn't do anything anywhere. There's a lot that can be done, and particularly we have dilution. I mean, the fresh air, the natural air. One can, if people have this increased awareness of how much you can actually work with what is naturally available, a very important tool in our toolbox. So one of the things also that delayed this recognition of aerosol transmission was also because various authorities, which you can understand that to some extent, had to say face one way or another. It's very difficult to accept that you did a mistake and to move on from that. Different authorities have done it differently, and some have not yet done it, or have done it very mildly and then just moved on and not implemented anything in practice. So this is something very important. We see some very good material coming out of WHO in the past few years, roadmap to improve and ensure good indoor ventilation in the context of COVID-19, indoor airborne risk assessment in the context of COVID again, and very interestingly with CERN as well. So here we're talking about very good collaboration between people that are predominantly using probabilistic evidence, which we tend to also mostly or mainly use, with those who predominantly use deterministic evidence, or let's say mechanistic evidence. So these are the kinds of collaborations we need more of. And there are various clear arguments why COVID is airborne. I've already shared some material, but this basically summarizes it, including things such as it being detected in air filters and building ducts. There's limited evidence to support other routes of transmission. Many things that were earlier on that could have been or were explained by contact transmission. The same setting, knowing that airborne transmission can occur, you can imagine that a lot of it was in fact airborne if people were not taking any airborne precautions. Let's see if this will play here. So this is just to imagine, you know, when the sun is shining through, some sun rays shining through inside the house. So this is maybe I should switch off the light. But you can imagine, and I'm sure you've seen it, the dust particles that collect. You can do it any day, every day. In this room, you could do it. So what you can see, the smallest size a human naked eye can see is about 100 micrometers. And that floats, at least for a while. So for someone who tells you that a particle that is 100 meters or plus or minus, I mean, this is just a very simple example of why it isn't so. So terms are important as well. It's very important what terms we use to describe different concepts. So when we say airborne, so some people also, the whole saving face thing or trying to walk back or whatever, or in the confusion of it, try to avoid using airborne. But okay, for clinicians predominantly, of course, not all clinicians, but generally speaking, for most, it meant long-distance transmission, such as measles, requiring an N95 FFP2 or FFP3 for infection control. For aerosol scientists, who are really the experts when it comes to anything to do with aerosols, I mean, someone who spends 10, 15, 20, 25 or more years of their lives studying a particular field probably knows more about it than others who don't. Of course, we need multidisciplinary collaboration, but we should be careful about transgression, being experts in other fields that we are not generally experts in. But interestingly, the general public, what does the general public understand by the word airborne? The air. And if you ask me, and for a lot of communication people, this is essential. People understand what airborne is. You tell them aerosol, droplet, they'll think, okay, it drops straight away. A droplet, nuclei, particle, they all have definitions, but when it comes to the general public, what are they understanding by this? This is very important to keep in mind. So we move on to a much smaller, much brief bit about the second part. And here we talk about deterministic and probabilistic evidence. I've already mentioned some material about this, but this is at the core of multidisciplinary collaboration. When we talk about physics, chemistry, engineering, we're talking predominantly about deterministic evidence or deterministic science informed from deterministic methods. Whereas predominantly in public health, in medicine, except maybe for the basic sciences to some extent, we predominantly use probabilistic evidence, and we need more collaboration happening between these two. You're familiar with the hierarchy of evidence. More and more, the evidence-based movement is accepting that it is a bit less rigid than this. But more importantly, we should recognize that there are other forms of evidence, particularly mechanistic evidence. They're nowhere here. They're nowhere. So this is a major challenge for multidisciplinary collaboration. We need to move from the traditional biomedical paradigm to complex systems paradigm. And here we're talking about not the glorification of randomized control trials or meta-analyses, which are important. They have a very important role. But we need to shift and also accept other forms of evidence, again, with our critical thinking. Not having a single design as the most valued, having a combination of designs, again, trying to answer different questions. critical thinking in mind. This is what confused a lot of people when it comes to masking. In many non-RCT studies, it's very difficult to untangle the issues. I mentioned earlier the challenge with the schools and measles and the experiment they did. They didn't think about the kids are already in a bus for a half hour, an hour. Transmission could happen there before it actually arrives to the school. So if I'm going to do a randomized control trial or any other at the level of the school without thinking of what's happening before or after school, it is quite a challenge. So, mask, strictly speaking, is not a respirator. This is a respirator. The more medical, surgical one is called a mask. But we're going to park that right now. It's not the most important thing. So the FFP filtering face piece respirator, strictly speaking, it has a pore size. And of course, you notice this is larger than of aerosols. But that's because it doesn't work as a sieve. It's not just a filter, to speak. There are different effects that work more or less for different sized aerosols. And then you have whole institutes, like in the NIOSH for occupational safety and health, whole national institutes that have been functional for 40, 50 years, who are experts at the deterministic evidence, the certification for these. So there's sedimentation, impaction, interception, diffusion, electrostatic effects. So by electrostatic effects, you catch a lot of also the most important sized particles or aerosols. So, then these are details. The most important aerosol size, plus or minus, is the 0.3 micrometers. Because of dynamics and physics, we know that these are the most dangerous or most threatening. So, and they're also the hardest to filter out. That's another very important factor. So the certification means it removes this amount of particles. It certainly removes far more than 95 or 99% of altogether of aerosols. And different issues that comes to masking, such as filtration efficacy, effectiveness. So here, in terms of filter effectiveness, this is going towards more. With the medical or surgical masks, the ear loop designs, then around the head. Then this is, again, the materials. So here it's mainly the issue of material that is making the difference. Excuse me, that is making the difference. And over here we have the fit effectiveness, because the fit is quite important. Interestingly, having a rubber brace, for example, around those medical or surgical masks considerably increases also their overall effectiveness. So because in many places we can't afford to have, or not we, but countries or institutions may not think they can afford to have everyone access FFP2 or FFP3 masks, then these are also better than nothing, certainly. Even a surgical mask is still better than nothing, 50, 60%. But you'll see that the challenge is that they have gaps when it comes to fit. You can have gaps, also gaps when it comes to other types of masks, because most of these masks have been made with the model of a white Caucasian male. That's also one of the things. So for different sized faces, you can have more or less fit. But we don't need to go into that level of detail right now, just to know that this is one of the challenges when it comes to surgical masks. They typically will have the sides. You could fold it in different ways to decrease the gaps, but we had 2 Cochrane reviews. For many of us, Cochrane is a gold standard, but they were very much mistaken in asking in 2 reviews questions that they couldn't answer. And they had to issue apologies also because some of the authors, the issue of conflicts of interest, some of the authors, for example, went after this review to say in the media that masks don't work. And so Cochrane itself had to take distance from those statements and also clarify what the study found, which was basically absence of evidence based on RCTs and observational studies. But they didn't even look at mechanistic evidence. So there's a whole discipline we're just leaving out in the corner. Again, with the Denmark in Denmark, Denmark 19 study, there are factors you need to consider, such as how much is the burden of COVID broadly in the population. And if someone masks for part of the time, we'll just shift into this very interesting review. And here we are talking about let me show this more clearly. We're talking about N95 respirators. They compared N95 respirators with medical masks. So just keep this in mind because it wasn't so impressive. Then they looked at continuous N95 use, and we see over here the impact when it comes to the risk ratios. And what's the difference? It's the continuous use. Because if I ask a nurse who has spent 3 hours or 4 hours on a ward, did you wear the N95 mask while you were on that ward? Yes. And then took it off and went to other wards or to the cafeteria in the hospital or to see other patients not there for respiratory diseases. So you can see how different biases start to fit in. So when it comes to continuous mask use, we see the impact. And still, despite all the challenges, the messiness in the real world settings, and people having either bad fit or not knowing so much about transmission. So different factors affect how far the aerosols can go. Again, this is one way to imagine it, not like this, but rather. Now, of course, when you're outdoors, the effect of dilution that we mentioned earlier is massive. You're going to have air currents around you, or even if you have flow, ventilation flow, or across here, or courant d'air, yani, if we open 2 windows particularly, 1 window is better than none, but ideally you want 2 windows or a window and a door. Start to get that. And there's a lot of mechanistic evidence. There's a lot of videos on YouTube if you're interested, showing experiments in Japan, South Korea, and places where they've done also a lot for public education and awareness. Again, this is a setup of a mechanistic experiment. SARS-CoV-2, this is again estimating by the CO2 concentration. So CO2 ends up being a proxy for the ventilation in a room, because the CO2 is roughly about 400, 440, 450 you'll find outside, sometimes more, depends on the pollution. But indoors it collects, because our breath, the breath we expire is 3.8% CO2. So the longer we are in a room, the more the CO2 increases. So with time and with increased CO2 concentration, we see that the infection probability increases. But there is quite a big difference between no mask and surgical or medical mask, and also between that and this. In the future, we're going to have more and more light, or far UV more specifically, in ceilings, in hospitals, and in certain locations, because basically it damages the RNA or DNA in viruses. There are quite some interesting innovations combining that with just the traditional fan, because you get the air circulating upwards. Ceilings also have quite an impact, because the higher the ceiling, as we know, warm air rises. So the higher the ceiling, the cooler the air at the top. So you start having flow going upwards. So for a short time, it would be relatively, let's say, safer or less risky to be in a room with a high ceiling. But it gets harder and harder as the ceiling drops and the air in the room is more uniform. And we've seen some experiments as early as 1997 with TB patients in wards with UV, and how impactful it was in terms of incidence of TB. There has been some public engagement and things on this, but still not so much. Ventilation, we see increasing, decreasing the CO2, increasing ventilation to decrease CO2. We can see how impactful it was regarding incidence. This is in a school, in a university, where they had TB cases followed up for 4 or 5 years or so. And we have also from broad regions like Italy's Marche region, they compared 10,000 classrooms with 316 where they had mechanical ventilation. And they saw the impact also, how much it actually approaches what they calculated theoretically would happen. So for every 1 liter per second increase, they had 12 to 15% decrease in relative risk reduction. And there are also different portable CO2 meters people can have to get an idea. So I've had this since the start. It's slowly increasing, 972. Roughly, if you want to know, outside it's roughly about 400 or so, 450 or so. For every 400 above that, you're breathing in about 1% of the air from other people's lungs. So that's one of the things. And yeah, so it's not 100% at least, but it's something. So it matters. This is just me 3-4 days ago before my flight. This is on the way to the airplane, it was 1,127. Later on in the flight, it was 1,561. It reached 2,000 at some point. And it's fascinating because by proxy, our human nature, when we feel cold, when we feel cooler, when we feel wind flow, that the air is better. That's, of course, our human nature. It's not adapted for modern day living, but that's the fascinating thing. The air in planes is particularly bad. So this is one thing, if you're going to musk somewhere, a plane would be a good place. Particularly, I mean, sometimes, well, it depends, during boarding or before, but this was all during the flight. This was during a train trip. And this was when I stepped out and then into the airport. The airport was actually not badly ventilated. And finally, until I stepped out. The ventilation also affects cognitive performance. There are a good number of studies showing how cognitive performance, particularly for complex tasks, starts suffering as you go beyond 1,000 parts per million, ppm of CO2. We just get worse at our tasks. So it's win-win if you improve ventilation. It's not just for COVID and infectious diseases, but also for our own work. And there are filtration. They've done this with the filters off and on in ICUs and seen how much the bioaerosol count in the air from different types of bacteria and COVID, the role of HEPA filters. These are box fan filters, and it's a pretty simple design. This is one I did quite a while ago. And basically what it does is, if you can't afford the HEPA filter, because they can be somewhat expensive, or for some people, it could cost $100 or more, you can go into several hundreds. But this was one design that was used in many schools in the US, not the majority, not by far, but in many places, they actually would gather kids in gyms and stadiums and construct these using 4 filters and then this. So you get the bad air with some pollutants, but also with COVID, with the SARS-CoV-2 virus, it gets stuck in these filters and then you get the fresh air out. So the difference is, of course, this might not be something for everyone to construct, but it's very cost effective. This costs about $70 or $80 and can last for quite a long time. With the commercial designs, you have to change the filters, which are more expensive. But still, it's worthwhile. It depends what you can afford. You get meeting of long COVID rehabilitation groups. If you look at the aerosol scientists and the conferences they make, it's also a very similar site. The initiatives like this is, for example, talking about air monitoring, ventilation at schools in France. And we have this increased absences we're seeing everywhere in schools and also in workplaces. This is people with disabilities in the US, it's increasing. So why? Why is that happening? We'll see in a moment. We have the World Economic Forum in 2023 in their meeting. They had also measures regarding COVID. They had HEPA filters here, they had ventilation. You'll notice they were wearing coats. The ventilation was very strong. Again, HEPA filter. Their coats again, and again, HEPA filters. So infection causes chronic impact, not only acute. Now, I'm going to cover this quite rapidly. But it's just to give you an idea, because there's far too many studies, and it's better that I show you this and show you a sample of these rather than make a broad generalized comments. But generally speaking, the health impact of COVID, we have the acute illness and the death, and people see this a lot, particularly the acute illness. The death, very often today, people don't know. People die of pneumonia, but they don't know what the cause is, or they haven't tested for it, or they've tested one test before there were enough virions to get a positive result. Long COVID is also happening and other chronic diseases. So these are also important sequelae that are happening. If you want to picture it, this is acute illness. Death is now somewhat submerged, but we see it in excess death, increasing mortality. We see long COVID a bit further down, and other chronic diseases are even harder, because if I get new onset diabetes, how am I going to know if it was because of my COVID infection last month or the month before or the month before? So it's quite a challenge. Long COVID, persistence of symptoms among persons who have survived from an acute infection. It hits about 10 to 30% of the persons infected. Of course, the more severe, the more likely you are to get long COVID. It can last anywhere from a few months, and there's people that have had it for 4 or 5 years. But so it's a patient-created term. It's also known as post-acute sequelae of COVID-19. Usually we count it as 4 weeks. There's no universal definition. There are different mechanisms that are suspected, including viral persistence. The virus hides in the human body in different tissues where the immune system can't reach it. Immune dysregulation. It actually damages your immune system. We now have very good evidence of damage that COVID is doing directly, indirectly, but also directly to immune cells in the body by disrupting your microbiome, the gut bacteria, endothelial inflammation, having microclots in the body in different organs, neuronal inflammation. We know it also damages the blood-brain barrier in people. And we have mitochondrial dysfunction. As you know, the mitochondria are the powerhouses of the body. So having symptoms like fatigue and tiredness. And fatigue sounds like such a soft word, but it's actually quite serious when you just can't recover from it day in, day out. So we have in various systems, the heart, lungs, immune system, pancreas, GI tract, across various systems. And of course, it's not necessarily that only one of these mechanisms is functioning or is the cause. It can be some combination also. This is in terms of prevalence. From different studies, we see how it varies, whether hospitalized or not hospitalized. And in different countries, again, prevalence of long COVID. Unfortunately, or in a way, fatigue is a very, very clear, very common symptom, but the problem with it is it's so easily brushed away, fatigue. But it is quite an important symptom to follow up on, and there are others as well. There's no cure yet for long COVID. There are some things, or at least I'm not going to get into the details of potential treatments and things of that sort, but at least the one thing you can do is when you are having an acute COVID infection, get as much rest as you can. If you do end up with getting long COVID, then again, try to get as much rest as you can, or avoid doing the things that you notice exacerbated. Because unfortunately, in some countries, the advice is being the opposite by some physiotherapy regimens and things of that sort, and that's only worsening long COVID. So hopefully one day we arrive at more cures. There are some things that in some patients or subsets of patients are turning out to be beneficial. So we see this is among healthcare workers, we have about a third of them reporting long COVID symptoms. I have 2 friends of mine, medical doctors, who have retired. They're my age. So they have retired because of long COVID. There are many others. I know so many people. I knew a lot of people in Lebanon because, of course, the social network is much broader. You see it among cousins, among friends. In Denmark, over the years, it started to pile up as well. And people typically get misdiagnosed. That's why it's very important to engage and medical societies with this. And we know post-acute syndromes are seen also in other diseases, like SARS-1. SARS-1 is about, let's say, 80%, let's say, similar to SARS-2, COVID-19. So we also saw some symptoms or post-acute sequelae, and we see it among other diseases as well. So it's not an entirely new thing. We find samples of SARS-CoV antigen in biopsies of patients after sometimes months after getting infection. These are details of different mechanisms that by also damaging your immune cells, the T cells and B cells. Again, these are other studies that are showing, we're talking about long COVID manifests in T-cell regulation. These are quite important studies because we start to see also that past COVID or previous COVID infection may be responsible for quite a substantial amount of the increase in other types of infections. And long COVID, again, large studies, online surveys, and again, we see the prevalence. And here, there's a question which is quite common to ask is, with additional infections, does it get better or worse? And here we have reported a mean score of symptom severity. We see one infection is in green. More than that is getting it twice. Getting COVID 3-4 times is still even more severe. So, of course, the jump from 0 to this is higher than the jump from this to this. But it doesn't matter if you're a person getting repeated infections, you're the one who's suffering. That's an important concept. And we see, for example, this is in Canada, except for Quebec. This is Quebec. Interestingly, they're using similar methods. They are at a similar conclusion. Getting long COVID increases as you go from 1 to 2 to 3 infections, 13%, 23%, 37%. We see damage accumulating in the body. Even if your acute illness can be milder, that is, in general, what we're seeing. The acute illness is somewhat milder, but the long COVID symptoms are becoming more severe if you have long COVID, and also you're adding, it's a cumulative risk of getting long COVID. We also see it, unfortunately, in children, also with Omicron, and also with repeated infections. Long-term cardiovascular outcomes. Again, across various systems, we see the hazard ratios, the absolute or excess burden per 1,000 persons, risk for newly diagnosed diabetes, long-term neurological outcomes of COVID. Again, we see across various conditions, cardiovascular disorders. Cognition is an important one. Sensory, musculoskeletal. This is a very important study that came out, the UK Biobank study, which compared records, MRI records of patients before catching COVID. They had these records and compared them to the changes that happened after. And we see in different parts of the brain. And yeah, it is quite unfortunate, and the brain has some plasticity, but still quite an issue. We actually have the evidence of where this is impacting. We'll go through these a bit faster. There are many studies, and I don't like to use the word top journals, but again, they are there. This is IQ. And here we see in terms of IQ loss, even with a mild infection, -3 points on a typical IQ scale. Even IQ is a misconstructed concept, but still, if you compare yourself to yourself, it's very much there. So if with every infection we're losing points, that's not a good sign. These are biomarkers for neurological outcomes. 6-month study, psychiatric outcomes are also increased. We see dementia, for example, other kinds of disorders. And even when we compare them to, yes, I know, but it starts late, so. I will, but I'm gonna finish up in 3 minutes and then I will. And so we're seeing that different impacts across various systems, and it's not so strange. With SARS-1, we also saw some of these, even though the sample was much smaller to work with, but we also saw various kinds of disorders. Autoimmune antibodies. So accelerated biological aging, we see the damage to telomeres and DNA, basically. Various impactful changes. Again, we're talking about exhaustion of T cells, of immune cells, and we're also seeing this increased risk of other diseases after catching COVID previously, like herpes zoster and TB. Other viruses also damage the immune system, like measles also causes, it wipes out to some extent the immunity you have to different diseases. And this is what we're starting to see from COVID as well. Many, there are so many studies. It's we can see. Let's jump a bit further. Even among kids, and here we're talking about those without congenital heart defects, we're seeing cardiovascular outcomes, arrhythmias, thrombotic disorders. And there's also a big question mark about the oncogenic potential of SARS-CoV-2 for future cancers, because there are studies coming out showing of damage, for example, to P53 or other aspects that are involved in. And there's no good respiratory infections. People have confused, a lot of people, bacteria, where we have good and bad bacteria, with viruses that are predominantly bad. We have not been with respiratory pathogens for a very long time. In the past 100 or 200 years, particularly, we have moved predominantly indoors. We have not been evolving with these respiratory viruses. We have been evolving with soil bacteria, good and bad to some extent, but respiratory pathogens is not something we are designed to deal with. And to wrap up, let's see. There are also defense mechanisms that people use consciously or unconsciously to deny or displace or rationalize any measures when it comes to COVID-19. So basically, there are various options and actions. I'd love to engage with you all today, many days or months from now, and feel free to contact at any time, because I think it would be a great success of today if we can follow up and continue this discussion. And otherwise, very big pleasure to be here with you. Thank you.
Thank you so much. Thank you so much, Dr. Khalife, for this very insightful and very comprehensive presentation. I'm just going to see if any questions. Okay, so just.
I have two questions. Well, I was wondering if you go back to the first slide.
The very
where
first one.
That showed the effects in Lebanon.
Yes.
Was the one I didn't get.
There's a sister seminar on strategies, which is very interesting, but I'm not giving it today. But it's a very interesting topic to get into. Where is it?
It's the very first slide.
Yeah. There.
Yes. This one. Yeah. So can perhaps you explain why the effects in Lebanon were particularly bad?
Well, it's similar to some other countries that try to mitigate COVID-19. And one of the important things we get also, particularly from complex sciences, and physicists are particularly good at understanding this, and I learned a lot from them, and others too, is that the more you allow a virus to get wild, to get widespread, you have more complexity. You're adding complexity. It becomes much harder to manage it. It's far easier to go upstream and intervene and decrease the number of factors you have to deal with. And that is the strategy the rest of the world should have done. East Asian countries were particularly successful at this partly because they had learned from SARS-1. So in SARS-1, they were able to squash that disease. And they were following a similar approach for SARS-2, but we saw most of the rest of the world didn't learn from that experience. And this is when we try to play and balance and open a bit, close a bit. And so, yeah. Thanks.
So let me just check if we have any questions from the online attendees. You can just like unmute yourself, or you could kind of type in your question.
Sorry, 1 second. It's going to show you, we faced challenges like this before, because these are just some photos from 50 and 100 years ago, during TB and polio, outdoor schools. This is a warming bag. They'd fill it with weighted stones. You had these massive windows. Why do old buildings and many old schools particularly, and hospitals have very big windows? Because they ventilated. Yes, yes.
Most of the articles. So I've noticed that most of the articles where you highlight the effect on cognitive or the long term, I mean,
Actually, they were like 2022, 2023. So do you think we had enough follow-up to establish and to come up with conclusion that it is not acute, it's chronic, and that it has an effect? And is it like a long-term effect? Because I think maybe we still need more follow-up. So what are your thoughts on that? Because I've noticed that most of the like 2022, like 1 or 2 years after the pandemic.
Yes, well,
Thank you for your presentation.
no, thank you. It's a very interesting question. The most relevant and impactful studies did come out, period. And there are more piling up. There are many that are showing the same and confirm the evidence that is coming up in these studies. And we are learning more, of course, today, but it's quite fascinating that these studies have been there since that time. There were even studies I showed back in February 2020, and before that, 15 years ago with SARS-1, showing what potential outcomes could be with SARS-2. And still, we're not acting on this. So that is about that. And then there are some other more recent studies as well, peppered here and there. Yes.
I wanted to ask this question.
It's much more than infection. Then can compare. So I don't know your thoughts on vaccination.
Yeah.
For those who were not.
Yes. So for yes, that's a really. It's an excellent question, and the problem, one of the reasons I don't go into that is because I thought this is far more important to get into rather than vaccination. But specifically on the vaccination, in many of these studies, they have compared people who have been vaccinated. Almost universally, you have worse outcomes in people who have not been vaccinated. Vaccination till today is also still somewhat protective. However, it has gotten less and less protective regarding, for example, long COVID or other sequelae. And from a conceptual point of view, it was wrong to think about a vaccine that is given in the arm for a coronavirus will actually protect us from getting it again and again, because the immunity that we get is not so much in where the infection is happening in the lungs, but rather more systemically. So by design, that may have been, or that was actually a very good tool to have in our toolbox, having the vaccination. And yes, they do have side effects, but far less infection, more than traditional vaccines, but far less than infection. And but it only should have been part of a longer strategy. Now they're working on intranasal vaccines that would give mucosal immunity, and that is where a lot of hope lies. But they're having challenges in getting positive outcomes. There are some big clinical trials happening, so that is a very important thing to us. But the next time we get another pandemic like H1N1 or some other virus, or we just don't have a vaccine, that is exactly. So that is why having awareness about ventilation and acting on it is the critical measure. Thank you.
Just there's like one question here from Nicola. If I wear a KN95 mask all day at work, will I be protected against COVID-19?
It's very difficult to quantify, but certainly that person will be more protected than not wearing the mask. But the other measures one can do is trying to open a window or two, or things of that sort. And I know some people who wouldn't walk into a meeting room unless they open a window or two.
I like this idea.
And that causes some friction sometimes, but you know.
Thank you so much.
Thank you. Thank you.
Thank you.